If I told you that just 500 grams of a certain biological substance could theoretically wipe out half the human population, you'd probably assume we were talking about like a highly classified, weaponized
Oh,
bioagent.
absolutely. I mean, it sounds exactly like something out of a science fiction movie.
Right. But what if I told you that exact same lethal substance is just naturally hiding in a jar of grocery store honey? Like
No.
actively targeting vulnerable infants.
Yeah.
And even wilder, what if I told you that we purposefully inject that very same deadly toxin into our faces to cure wrinkles?
Yeah, it really does sound made up. But, that is the reality of human physiology. Nature doesn't deal in these simple good and bad categories. It deals in mechanisms and doses and these microscopic vulnerabilities.
Wow.
And understanding the absolute precision of those mechanisms, well, that's what separates casual medical knowledge from true clinical mastery.
Which brings us to our mission for today's deep dive. So whether you are a medical student staring down the barrel of your board exams or, a young professional trying to hone your clinical acumen on the wards, or maybe you're just a deeply curious learner who wants to understand the mechanics of the human body, this is for you. We are extracting the most high-yield clinical knowledge from the NMS Q&A USMLE Step 2 CK, the fourth edition, edited by Drs. Kenneth Ibsen and Nandan Fott.
Right, and our goal today is to go far beyond just a dry recitation of medical factoids. The sources we're exploring, they function as an active masterclass in clinical reasoning.
Which we desperately need.
Exactly. We are going to dissect complex patient vignettes, connect the underlying pathophysiological mechanisms, and map out the common diagnostic traps that board examiners and real-life diseases set for you.
The stakes are incredibly high, and honestly, there's a real thrill to solving these clinical puzzles. But let's unpack the blueprint first, because before we dive into specific pathologies, we need to talk about the mechanics of the test itself.
Yeah, we have to.
The text makes a massive point about what the Step 2 CK exam actually represents for a medical professional.
It really does. Because the transition from Step 1 to Step 2 CK, which stands for clinical knowledge, by the way, it's a fundamental pivot in a medical career. Step 1 largely tests basic science recall. Like, do you know the biochemical pathways?
Right, the memorization stuff.
Exactly. But Step 2 CK tests application. It asks the ultimate question. Can you safely transition into the hospital environment and care for a living, breathing patient under supervision?
And the book is absolutely brutal about how you must prepare for that shift. I mean, it explicitly states that passive studying, just reading your notes and highlighting the same text over and over, that almost guarantees failure. You have to engage in active concept formulation.
Because merely memorizing that, disease X causes symptom Y, that leaves you completely helpless when the exam or a real patient presents symptom Y in a bizarre, atypical way you've never seen before.
Yeah, they never read the textbook, right?
Exactly. You need to grasp the central concept, the underlying why, so you can extrapolate the diagnosis. And you must do it under extreme duress. I mean, the time management is unforgiving. You have approximately 72 seconds per question.
Wait, 72 seconds. That is insane. To read a dense paragraph about a complex patient, analyze their labs, synthesize their vital signs, and decide what life-altering action to take next, that's just a massive cognitive load.
It is. It's by design.
So, since there's no penalty for guessing, the text says you must answer every single question.
But
Here's something that confused me. The book is adamant about never taking a trial run of the USMLE.
right.
And honestly, in almost every other high-stakes professional, law, aviation, professional sports, simulating the actual environment in the real arena is standard practice.
Mm-hmm.
So why is medicine penalizing a dry run?
I get why you'd ask that. The logic makes sense on the surface, but a trial run in this specific environment is a massive career-altering trap. Yes. Because any attempt you make on the USMLE goes onto your permanent professional record. If you walk in just to see what the pressure feels like and you happen to guess well enough to pass but with a terrible score, you are burdened with that low score forever.
Oh.
You cannot retake a past exam to get a better grade. Every residency director in the country will see that low score.
So you're permanently stuck with a barely passed on your resume just because you wanted a practice run.
Exactly. And the risk extends even if you fail the trial run, because while failing doesn't technically prevent a retake, different states have incredibly strict legal limits on how many total attempts are admissible for you to obtain your medical license.
Wow, I had no idea.
Yeah, if you waste an attempt on a trial run, you are needlessly diminishing your ability to be licensed in certain states. So the source strongly advises utilizing full 9-hour simulated practice exams on your own time instead. You build the cognitive stamina without the permanent catastrophic risk.
Okay, that makes total sense. You build that 72-second analytical mindset in a safe environment before you step into the arena.
Precisely.
So let's apply that rapid-fire mindset right now. We've seen how macro-level strategies dictate your career. Let's see how macro-level blockages dictate human survival. We are going into one of the most time-sensitive clinical emergencies in medicine, acute neurology.
Oh, this is a big one. In acute neurology, jumping to a treatment conclusion without the proper imaging isn't just a mistake.
Yeah.
It can be immediately fatal to the patient.
Right. And the source text gives us this terrifyingly common clinical vignette.
Yeah.
So you have a patient who is already taking warfarin, which is a powerful systemic blood thinner, and they suddenly present to the emergency room with severe symptoms of a right cerebral hemisphere stroke,
A very stressful situation.
to say the least. The question asks for the immediate, critical next step in management. And answer isn't a drug. It's a non-contrast computed tomography scan, a CT scan of the brain.
And the clinical reasoning here hinges on the definition of a stroke. Because stroke is merely a syndrome, it just describes the sudden loss of brain function due to a disruption in blood flow.
Okay.
But as a physician, you must immediately differentiate between two completely opposite mechanical causes. Is this an ischemic infarct, meaning a physical clot is blocking a blood vessel? Or is it a hemorrhagic stroke, meaning a blood vessel has actively burst and is bleeding out into the brain tissue?
Because the treatments are total opposites. It's kind of like a crisis with your home plumbing, right? Like if water stops coming out of your kitchen faucet, you have to check if the pipe under the sink is just clogged with food, or if the pipe is actually ruptured and is actively leaking water into your walls.
That's a great way to think about it.
Right, because you have to figure that out before you pour harsh caustic chemical drain cleaner down the sink.
Exactly. And if you pour that caustic chemical down an already ruptured pipe, it eats through the remaining structure and completely destroys the inside of the house.
That would be a disaster.
And in the human brain, if the stroke is caused by a clot, you want to administer anticoagulants to dissolve the blockage and restore blood flow. But if the patient is suffering from a hemorrhage and you blindly administer a blood thinner like heparin, you exacerbate the bleeding exponentially and likely kill the patient.
Oh, man.
So the non-contrast CT is incredibly fast and highly sensitive for detecting fresh blood. It visually rules out the hemorrhage, allowing you to safely rule in the ischemic treatment protocol.
You verify the structural integrity of the pipes before you thin the blood. That's wow. Now, the text notes another trap students fall into with this vignette involving antiplatelet agents like aspirin or clopidogrel. I mean, people naturally associate aspirin with saving lives during heart attacks, so they just assume it's the right acute move for a stroke.
Yeah, that's a common misconception. The text clarifies a vital pharmacological distinction there. Antiplatelets are fantastic for the long-term, chronic prevention of strokes by keeping platelets from clumping together over time.
Prevention.
Right, but they are entirely inappropriate for the initial acute management of an event that is actively unfolding in the emergency room.
Precision under pressure. I love it. Now, while we are looking at the brain, the text contrasts two conditions that both severely affect cognitive function, but look vastly different on presentation. That's Alzheimer's disease versus progressive multifocal leukoencephalopathy, or PML.
Yeah, this tests your ability to distinguish between a slow degenerative dementia and a rapid infectious assault on the brain. Alzheimer's disease typically presents with insidious behavioral changes, memory loss, and personality shifts.
Right.
But crucially, their motor function is usually preserved in the early and middle stages. A patient might tragically get lost in their own neighborhood because of the memory deficit, but they physically walked out the door just fine.
Right, their legs still work perfectly. But PML operates on a completely different pathophysiological mechanism. The text explains PML is caused by a papovavirus, and this virus breaches the brain and actively destroys the oligodendrocytes. Those are the specific cells responsible for insulating the nerves and the white matter of the brain.
Exactly.
But the text notes this opportunistic virus usually only attacks immune-compromised patients, like those with advanced HIV.
Right, and because the virus is physically destroying the white matter, the brain's electrical wiring PML presents with stark focal neurologic deficits.
So not just general memory stuff.
No, you won't just see generalized memory loss. You will see things like hemiparesis, which is profound weakness on one entire side of the body, or sudden seizures. Identifying that focal motor deficit in an immunocompromised patient is the linchpin of that 72-second diagnosis.
We've seen how macro-level blockages in blood vessels cause strokes and how viruses destroy brain wiring. But blockages don't have to be the size of a blood clot to be lethal. Sometimes the blockage is entirely microscopic, happening at the neuromuscular junction. And this creates a truly terrifying emergency in pediatrics.
Oh, absolutely. Pediatric patients are not just tiny adults. Their anatomy, their baseline physiology, their immune systems, they react entirely differently to external triggers.
So the case in the text is infant botulism. A 26-day-old infant is rushed into the ER. The baby has generalized weakness, a terribly weak cry, severe constipation, and profound loss of muscle tone, what's often referred to clinically as floppy baby syndrome.
It's heartbreaking to see.
And the culprit hiding in the background of this vignette, a small taste of honey.
The pathophysiology here comes down to the microscopic environment of the infant's gastrointestinal tract. The text details that infants under 1 year of age naturally have a relatively high stomach pH.
Meaning it's less acidic?
Right. Their stomach acid is significantly less acidic than a fully developed adult's. And this matters because raw honey frequently contains the dormant spores of the bacteria Clostridium botulinum.
But if a healthy adult eats that honey, our highly acidic stomach acid destroys the spores instantly, right?
Exactly. But in the infant, that higher, gentler pH provides a safe harbor. The spores survive the stomach, travel to the intestines, germinate, and begin actively producing the botulinum toxin.
Wow.
And this toxin is a microscopic blockade. It works by preventing the release of the neurotransmitter acetylcholine at the neuromuscular junction. Without acetylcholine, the nerves cannot tell the muscles to fire, resulting in a creeping flaccid paralysis that spreads across the arms, legs, trunk, and ultimately the respiratory muscles.
That is terrifying.
Yeah.
And the lethality statistics provided in the text are almost incomprehensible. I mentioned this in the intro, but only 75 nanograms of this toxin can kill a full-grown adult.
A microscopic amount.
Yeah. The text notes that just 500 grams, barely over a pound of this purified substance, could theoretically kill half the human population. It is one of the most acutely lethal biological substances known to science.
Which is why the plummeting mortality rate is such a triumph of modern medicine. The text points out that the death rate for infected patients has dropped from a terrifying 50% down to just 3 to 5% over the last few decades.
But how is that even possible if the toxin is so potent?
It is the result of modern immunology, specifically the development and rapid administration of tri- and heptavalent equine antitoxins.
Equine, like horses.
Yes, exactly. We essentially use a cocktail of antibodies that have been incubated in horses. These equine antibodies are designed to bind up multiple different strains of the botulinum toxin circulating in the infant's blood before the toxin can irreversibly attach to the nerve endings.
That is brilliant.
Combined with mechanical ventilation to breathe for the baby while the paralyzed nerves slowly regenerate, we can save their life.
Wow. And here is the profound medical irony the text highlights. This exact same deadly toxin, the one we frantically keep away from infants, the one that paralyzes the diaphragm, is Botox.
Yeah, we have meticulously tamed nature's deadliest weapon. The text notes that when the toxin is highly purified and administered in unbelievably minuscule targeted doses, we use it therapeutically.
Right.
We purposefully paralyze specific overactive muscles to treat strabismus, which is severely crossed eyes. We use it for blepharospasm, which is uncontrollable, debilitating eyelid twitching. And of course, it is injected cosmetically to paralyze facial muscles and smooth out wrinkles.
The absolute epitome of the dose makes the poison.
Truly.
Now, keeping our focus on pediatric emergencies and the vulnerable gut, the text presents a fascinating mechanical issue: intussusception. It's the most common cause of intestinal obstruction in children between 3 months and 6 years of age.
And the clinical presentation is a classic board exam staple. A young child presents with paroxysmal colicky abdominal pain, meaning the pain comes and goes in intense screaming waves. When the physician palpates the right upper abdomen, they feel a distinct sausage-shaped mass, and the diaper reveals what the text famously describes as current jelly stools, which is a dark mixture of stool, blood, and mucus.
The pathophysiology isn't an infection, though, right? It's structural.
Correct.
A segment of the child's intestine essentially telescopes inside of itself. It's kind of like pushing the sleeve of a sweater inside out.
Yeah.
As it folds inward, it drags the mesentery and the local blood vessels along with it. That telescope section of bowel is what forms the palpable sausage-shaped mass.
And as those blood vessels get dragged inside, they become severely compressed. This cuts off the blood supply, leading to rapid ischemia of the bowel wall. The dying tissue bleeds, mixing with intestinal mucus, which creates that classic current jelly stool.
But the intervention here is incredibly elegant. The text outlines the use of a barium or an air enema. And this procedure doesn't just provide imaging to reveal the diagnostic coil spring sign showing the telescope bowel. The actual hydrostatic or pneumatic pressure of the enema can therapeutically pop the telescoped intestine back out into its normal position, curing the obstruction right on the radiology table.
It is non-invasive, simultaneous diagnosis and treatment. It's amazing.
So we've seen how mechanical telescoping causes ischemia and how an external trigger like honey causes paralysis. Let's trace how another highly common external trigger causes a massive systemic autoimmune collapse in the adult gastrointestinal system.
Ah, celiac disease. This is a brilliant example of how the USMLE tests systemic pattern recognition. They don't just want you to memorize gastrointestinal symptoms, they demand that you understand how inflammation in the gut manifests on the skin.
Okay, so the text defines celiac disease as an autoimmune disease triggered by antibodies directed against the gliadin fraction in gluten, which is a protein found in wheat.
Right. When a genetically susceptible individual ingests gluten, their immune system mounts an aggressive inflammatory attack specifically targeted at the lining of the small intestine.
Okay.
This chronic inflammation leads to villus atrophy. The villi are the millions of microscopic, finger-like projections lining the intestine that create a massive surface area to absorb nutrients.
I always picture those intestinal villi like a thick, highly absorbent shag carpet. They soak up the fats, proteins, and carbohydrates you eat. But the autoimmune response to gluten acts like a lawnmower, just chopping that delicate shag carpet down to bare, flat floorboards. The mucosa undergoes complete atrophy.
That's a perfect analogy, and without that carpet, you have absolutely zero surface area for absorption. The fats and carbohydrates just slide right past, which is why these patients present with such severe malabsorption.
Makes sense.
The unabsorbed fat passes through, leading to greasy, foul-smelling stools known as snatorrhea, and the lack of carbohydrate and protein absorption leads to profound weight loss and severe fatigue.
So how do you confirm it?
To diagnose it, the text utilizes the D-xylose reabsorption test. This is an excellent screen for small bowel mucosal damage because D-xylose is a simple sugar that is normally absorbed easily without needing any pancreatic enzymes. If D-xylose isn't absorbed, you know the mucosa itself is destroyed.
But here's the systemic clue the text warns us about. The examiners will not hand you a patient simply complaining of stomach pain and greasy stools. They're going to describe a patient who comes into the clinic complaining of an intensely itchy, blistering rash on their elbows and knees.
Right. That rash is dermatitis herpetiformis. It's vesicular skin lesion caused by IgA antibody deposits, and it has an almost 100% correlation with underlying celiac disease.
Wait, an elbow rash for a gut issue? That's wild.
It is. The board examiners will describe the blistering elbow, casually mention some chronic diarrhea, and demand that you make that 72-second cognitive leap to anti-gliadin antibodies, villus atrophy, and the absolute necessity of a strict gluten-free diet.
So if you take nothing else away from this section, remember that the body is deeply interconnected. Celiac disease shows how an external trigger unleashes an internal autoimmune defect. But what happens when the trigger is entirely internal from birth? Like what happens when a genetic mutation programs multiple different organs to spontaneously develop tumors decades later?
We are zooming in on endocrinology now, specifically the multiple endocrine neoplasia syndromes, or MN. This requires recognizing complex, multi-system genetic domino effects.
The text provides a vignette of a patient who presents with bilateral pheochromocytomas, which are tumors of the adrenal glands that dump massive amounts of adrenaline into the blood.
Right.
This same patient also has a parathyroid adenoma, completely destabilizing their calcium levels, and an oversized cancerous thyroid. The text identifies this specific triad as MNN2A or Sippel syndrome.
Categorizing these syndromes rapidly is essential. All MN syndromes are autosomal dominant, meaning inheriting just one copy of the mutated gene from a parent is enough to guarantee the disease.
The text heavily distinguishes the underlying genetics here. So MN1, or Vermeer syndrome, involves tumors of the parathyroid, the pancreas, and the pituitary gland. This is linked to a mutation on chromosome 11.
Incorrect.
But MEN2A and MEN2B are caused by a completely different mechanism, a mutation in the RET proto-oncogene located on chromosome 10. And here is where the why becomes fascinating. The text notes this specific gene is expressed in cells that originate from the neural crest during embryonic development.
Yes, and this is the critical embryological link. During development, neural crest cells start near the spinal cord, and physically migrate outward to form different parts of the body.
Okay.
Some migrate down to form the medulla of the adrenal glands. Some migrate to the neck to become the C cells of the thyroid. If those migrating cells carry the RT mutation from day one, every location they land in becomes a ticking time bomb.
Oh, wow.
Decades later, a single genetic typo causes tumors to erupt in all those different, seemingly unrelated anatomical locations.
It's incredible. So it's like a ticking time bomb from birth. MNN2A typically presents with medullary thyroid carcinoma in over 90% of cases, plus the parathyroid issues and the adrenal pheochromocytomas. MNN2B is caused by a similar mutation, but includes unique physical manifestations like mucosal neuromas, which are little nerve tumors bubbling on the lips and tongue, along with a Marfan-like, tall and lanky body structure.
And the clinical application here is vital. Because these syndromes are autosomal dominant, we know they run heavily in families. You don't just wait passively for the tumor to grow in the patient's children.
You have to act.
Right. Because the medullary carcinomas of the thyroid in MN2A derive from those embryonic C cells, which synthesize the hormone calcitonin. Measuring the patient's serum calcitonin is the ultimate screening test.
You use the specific hormone the cells produce as a biological tracking beacon.
Exactly. And you can actively test the family members using provocative stimulation tests.
Yeah.
By administering calcium or pentigastrin, you effectively poke the C cells. If the calcitonin levels spike abnormally high, you have identified an at-risk family member who carries the RET mutation very early. This enables surgeons to perform life-saving prophylactic thyroidectomies, surgically removing the thyroid before the aggressive cancer ever has a chance to develop.
That is proactive medicine at its finest. We've zoomed in from systemic symptoms to embryological genetics. Now let's zoom in even further, down to the molecular level, to examine the leading cause of death globally: coronary artery disease.
The text forces a complete redefinition of what a heart attack or myocardial infarction actually is. It is not just a simple slow plumbing issue. It is a highly volatile, active, inflammatory molecular event.
This honestly blew my mind.
Yeah.
We are universally taught to picture a heart attack like a slow buildup of rust inside an iron pipe. Decades of a poor diet slowly clog the artery layer by layer until it finally just closes shut. But the text says that's not how most fetal MIs happen. It states most are caused by a suddenly ruptured atherosclerotic plaque followed by massive instantaneous thrombosis.
Right. The gradual narrowing of the arteries certainly causes angina, that predictable chest pain when you exert yourself because blood flow is restricted. But the sudden fatal heart attack, that occurs when a plaque hidden inside the vessel wall physically bursts open.
So the rust in a pipe analogy completely fails to capture the danger. It's much more like a dangerous blister growing inside the wall of your blood vessel. You have this lipid core, a toxic pool of fat and cholesterol sitting inside the wall, and it's held back from the bloodstream by a very thin skin, a fibrous cap.
The structural integrity of that fibrous cap is everything. The text points directly to the mechanism that destroys it: inflammation and the activity of microscopic enzymes called matrix metalloproteinases.
It's like the body sends in a microscopic maintenance crew to remodel the tissue around the blister. But because there is such a high concentration of lipids and a massive swarm of inflammatory immune cells called macrophages, the maintenance crew goes totally rogue.
Yes, the metalloproteinases become wildly overactive. They actively dissolve and eat away at the collagen holding the fibrous cap together. They aggressively thin out the skin of the blister
Until it violently pops. The fibrous cap ruptures, spilling its highly thrombogenic fatty lipoidal contents directly into the rushing bloodstream. The blood reacts to this spilled toxic material by instantly forming a massive clot over the rupture, entirely occluding the vessel.
Right.
Blood flow stops, and the heart muscle tissue begins to die.
And connecting this molecular mechanism back to clinical management is why physicians are so aggressive with statin drugs in controlling metabolic syndrome.
It's not just about shrinking the clog.
Exactly. When you lower a patient's lipids and reduce their systemic inflammation, you aren't just trying to slowly shrink the physical size of the clog, you are reducing the macrophages. You are turning off those rogue metalloproteinases. You are actively thickening and stabilizing that fibrous cap so the blister never pops in the first place.
If you take nothing else away from this deep dive, let it be this. A heart attack isn't a passive clog you can ignore until the last minute. It's an active, volatile inflammation. Okay, let's synthesize the core philosophy we've extracted today from the NMS Q&A. Mastering clinical medicine is about understanding the dynamic, living pathophysiology of the human body.
It really is.
It's knowing why a non-contrast CT must precede blood thinners to avoid destroying a ruptured vessel. It's linking an itchy elbow rash directly to a flat, inflamed intestinal mucosa starved of surface area. It's tracing a genetic typo in a migrating embryonic cell to a thyroid tumor decades later.
It is the cognitive leap from memorizing the name of a disease to fundamentally understanding how it dismantles the body.
And as promised to our clinical learners, it is time for your end-of-dive interactive review exercise. We are going to test your 72-second recall based strictly on the text we covered today. Think critically about the mechanical pathophysiology. Here is your question. A 3-year-old child presents to the emergency room with severe paroxysmal colicky abdominal pain. You palpate a sausage-shaped mass in the right upper quadrant, and the parents report the child passed a stool that looked like currant jelly. What is the most likely diagnosis, and what intervention can act as both the diagnosis and the therapeutic treatment?
Visualize the anatomy. Think about the mechanical telescoping of the bowel causing that ischemia.
Okay, time's up. The diagnosis is intussusception, and the intervention is an air or barium enema. The hydrostatic pressure reveals the classic coil spring sign on imaging and simultaneously pushes the telescoped bowel back into its proper anatomical position, reducing the obstruction.
If you visualize that mechanism, you are successfully formulating central clinical concepts.
Absolutely. Now, I want to leave you with a final provocative reflection to mull over today. Think back to the botulinum toxin we discussed. The exact same biological substance that requires us to frantically keep honey away from vulnerable infants, the microscopic blockade that can paralyze respiratory muscles and kill a human with just 75 nanograms, is now synthesized in sterile labs to treat excruciating migraines, stop debilitating eyelid spasms, and smooth out cosmetic wrinkles.
It is a profound duality that exists throughout all of pharmacology and medicine.
It really is. It forces us to ask, how many other deadly, terrifying pathologies in nature are out there, just waiting for us to uncover their precise therapeutic dose? Keep questioning, keep studying, and keep diving deep. Because the next time you are faced with a clinical puzzle and the diagnostic warning lights are flashing, you won't be looking for a simple answer. You will understand the mechanisms hidden beneath the surface, and you will be ready to navigate the muddy waters of real medicine.